All right. Good morning, good afternoon, depending on where you are in the country. Let's get started. Welcome to today's webinar, Mobilizing the Power of Lived Experience to Improve Health Outcomes for All. This is the final webinar in our three-part series called Engaging with Everyone. Next slide, please. My name is Andrew McLeod. I'm the Manager of Stakeholder Engagement at Canadian Blood Services. As with your last 2 months hosts, Heather Thiessen, Caroline Wong, and Belinda Boyd, I am also part of the leadership team for the National Health Engagement Network, and I'm pleased to be your host today. Please note that this session is being recorded. Next slide, please. Before we get started, I have a few housekeeping items. Please to offer French simultaneous translation interpretation provided by Boost Events, a subsidiary, of Boost Lingo for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If you do not see the interpretation menu on your screen, please select the icon with the 3 dots inside a circle, the More menu, and it will be on the toolbar at the bottom of your screen, and then select Interpretation. For the slide visuals, we invite you to access the View Options menu at the top of the slides to select the language in which you wish to see today's slides. If you are using a newer version of Zoom, you can choose the slides you wish to view by selecting the appropriate tab from the top of your Zoom screen. Next slide. We'd like to start today in a good way by acknowledging that we are meeting today across lands that have been inhabited by Indigenous peoples for thousands and thousands of years. I live on the shores of Lake Ontario in Toronto, a name from the Mohawk Takaronto, meaning the place in the water where the trees are standing. This is the land of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, this meeting place is still home to many Indigenous peoples. I am grateful to live and learn in this place, and as part of a truth and reconciliation journey, both personal and collective, I want to acknowledge that I am a settler on this land. We are gathering virtually today from sea to sea to sea, and so I invite you to please introduce yourselves in the chat and reflect upon the lands where you live, work, and play. If you're unsure, you can look to native-land.ca for guidance. Next slide, please. We invite you to share your questions and comments at any point during the session today using the chat box, which will be addressed during the question and answer period following the presentation from our speakers. We'll also be dropping our email in the chat box for you to connect with us on any questions you have. If you need technical support at any time during the webinar, you can reach out to tech support from the drop-down list in the chat feature. At this point, I would also like to give a huge thank you to the Healthcare Excellence Canada production team and the interpretation team who are working furiously behind the scenes to make sure this is a smooth experience for all of us. Now, as with the last 2 sessions, we do want to take a few minutes to get an idea of who is in the room with us today. So you'll see hopefully a poll pop up on your screen, and we invite you to answer 2 questions. So please make sure you scroll down to complete both questions prior to clicking the submit button. Well, thank you for joining us as we move into the final session of this 3-part fall series focused on equity promoting patient engagement, hosted by the National Health Engagement Network in partnership with Equity Mobilizing Partnerships in Community, or EMPaCT, at Women's College Hospital, and supported by Healthcare Excellence Canada. For those who aren't familiar, the NEN is a national community of practice made up of healthcare leaders, providers, patient and family partners, and essential care partners. Our goal is to advance patient and public engagement in the health system by sharing information, best practices, and resources, by building capacity for implementing effective engagement and partnership strategies, and by promoting collaboration among a diverse range of disciplines across the country to drive national patient engagement initiatives. Equity promoting patient engagement is core to NEN's mission, and this series has already served to deepen our collective knowledge, help build capacity, and promote initiatives that center equity in patient engagement. If you're interested in learning more about the NEN, please visit the NEN webpage on HEC's website. If you're interested in joining the network, please get in touch by email, and we'll share both of those in the chat. This webinar series, guided by the EMPaCT team, has been exploring critical questions about equity promoting patient engagement. The first session, we explored key principles of equity-oriented patient engagement, including co-designing safer spaces and building meaningful relationships. In the second session, we explored how power imbalances impact patient engagement and learned about sharing power to create safer, more inclusive spaces for meaningful involvement. This brings us to today's session, where we will explore a community-engaged approach to health equity analysis, co-developed by EMPaCT. Our speakers, including 2 members of the EMPaCT team and 3 health system professionals who have collaborated with them, will share how they have applied this approach to transform policy, practice, and research efforts. Together, we'll reflect on lessons learned from co-creating solutions that prioritize the voices of those most impacted by health inequities, and discuss strategies to mobilize lived experiences at the system level to improve health outcomes for all. EMPaCT is a novel and scalable patient partnership model, co-designed to center the voices of diverse community members and build capacity for equity-promoting, patient-oriented decision-making in healthcare. It was co-initiated in 2020 by patient-oriented researcher Dr. Ambreen Sayani and patient partner Elise Navy, who set out to challenge exclusionary patient engagement practices in healthcare, both of whom are here today and have been with us throughout this webinar series. Since 2020, EMPaCT has been mobilizing the power of lived experiences to ignite a health equity movement with a vision for a future where health and social care systems are inclusive, just, and shaped by the people whose lives are most impacted. The next slide, and over to you, Ambreen.
Thank you so much, Andrew, for such a good lead up into what we want to talk about today. I want to start by saying today's session is really about change. We've spoken to you over the last 2 sessions about different aspects to get us here, but it was really the seeding of an idea at Women's College Hospital and the support that we had to take this from a tiny little thought into the flourished idea that we have right now. Also generous funding from the Canadian Institutes of Health Research, not just to grow EMPaCT, but also to be part of this webinar series. The National Health Engagement Network, you have hosted us for these 3 very generous sessions. And Healthcare Excellence Canada, so much work behind the scenes has gone to put us here. But today is about change. The vision that you see on this slide is not just one from EMPaCT, but it is also one shared by the 3 champions of change on our call today, Carolyn, Shari, and Karen, and they will introduce themselves shortly. But also the over 900 participants who have signed up for this webinar. So thank you and welcome to this final of a 3-part series. Next slide, please. And Elise, over to you.
Yeah, so when we co-created EMPaCT, the group decided on some basic rules of engagement in order to keep our space safe. And we'd like to adopt them here today with you. So the first is to speak from our experiences, but from the heart, not the head. The second is to listen from our hearts, not thinking about what we want to say while others are speaking. And the third is to trust ourselves and our inner voices, not putting forth ideas that we think we ought to have or that people have told us to have. And then finally, we want to be considerate of group time. We have just this time together, and the purpose is to learn and share. Next slide, please. So this is us. Our community members are shown here, and to learn more about them, you can go to the website where each have shared what they're comfortable with sharing, so you can get to know them. We don't label people or use prescribed categories to bucket them because we think labeling individuals is restrictive and sometimes harmful. What unites us all is the shared value of helping to create an inclusive health system. Next slide, please. So let's introduce ourselves. I'll start with myself. I'm Elise Maybe, and I've been a patient partner since 2011, starting with doing QI projects at my local hospital, then getting involved with my local health authority, and moving on to research and policy. As a usual suspect, a white, female, older person, I appear to represent the majority of patient partners in Canada. And I'm frequently asked, how do we engage with others not like you? Cracking this nut is central to moving patient partnerships to the next stage. When I met Ambreen, we found we shared a deep interest in advancing health equity and in looking at different ways to engage with people seldom found at healthcare tables. So this brought us to co-initiating EMPaCT. And now I'm going to turn it over to first Shari, then Carolyn, and then Karine, and finally Ambreen to introduce yourselves. Shari?
Hi, everybody. So great to be here today. Sherry Fraser, and I am a patient advocacy lead at Novartis Canada. I've been working at Novartis now for just over 6 years. And in my role, I work with patients, caregivers, and patient organizations to ensure their perspective is embedded in our work when we're developing medicines and programs for Canadians. From a personal side, I am a second generation Canadian. My parents are Guyanese, and they came here to Canada in the early 70s. And I have 2 kids and also a husband. My daughter, Amaya, is 11, and my son, Javen, just turned 8 yesterday. Wanted to be up till the late hours to celebrate. So reasons why I'm tired today, but so happy to be here and appreciate the invitation from Ambreen and Elise. And I know I have supporters that are watching online today, so thanks so much for the encouragement from everybody. So looking forward to a great discussion. I think I'll pass it to Carolyn.
Thanks, Sherry. Hi, everybody. My name is Carolyn Steele-Gray. I'm primarily a scientist, so I come in from the research end of things. And my scientific role is at Sinai Health and the Science of Care Institute and the Lunenfeld Tenenbaum Research Institute, as well as being an associate professor at the University of Toronto. I also have the opportunity to hold a Canada Research Chair in implementing digital health innovation. And a lot of our work is kind of patient-oriented in nature, and what we're trying to do is advance person-centered models of care. So doing kind of patient community caregiver partnership is really core to what we do, and some of what I'll be talking about today. I'll place my land acknowledgement just in the chat here. But just noting that my family kind of settled from Russia and Ireland back in the early 1900s from very challenging spaces. Coming from a Jewish family in Russia, there was quite a bit of fleeing, coming and seeking safety in a new country. On a personal note, I've got 2 kids as well. I've got a 12-year-old who got braces on early this morning, and an 8-year-old who is delighted by the braces having Christmas-themed colors. We're also very delighted at the overlap of Hanukkah and Christmas this year that are right on the right first day together, which is always very fun. A partner I've been with a long time. And I'm also an endurance athlete, as evidenced by the many bicycles behind me. I'm very happy to be here today and representing my whole self. And thank you for the opportunity for that, Amber and Elise. And with that, I'd love to hand it over to Karine.
Thanks, Carolyn. So, hi everyone. My name is Karine Patton. I'm going to put my land acknowledgement in the chat as well for you there. I'm a senior policy analyst with Health Canada. I've been here between here and the Public Health Agency for about 10 years. I actually come from a background, I'm a clinical physiotherapist by training. I'm currently working on pharmaceutical drug policy, so that kind of area called pharmacare, but it was my previous work that was done in support of the launch of the new Canada's Drug Agency that introduced me to the world of EMPaCT and obviously Elise and Ambreen. I'm happy to say that I'm honored to be able to live, work, and play in the Ottawa area. My background is I've been probably, I think I'm fourth generation Canadian from the Ottawa Valley area. My family is mostly from Ireland, came over to build the railroads. So we've been here quite a while, but I'm honored to be able to say that I live here, and I'm super excited about all the snow that we got yesterday. I'm not sure if anyone else is from Ottawa and as excited as we are, but I've got some very excited kids that are ready to get out there and much like Carolyn, be the endurance athlete and get back on their skis. I'm also a mom to two busy teenagers, and I have a very adorable and cute middle-aged boxer that keeps me busy at all times. So very excited about the discussion for today, and I will hand it back now to Ambreen.
Thanks so much, everyone. It is such an honor and privilege to be here with the three of you today to talk about this. As for myself, I wear three professional hats. I am a physician. I've trained as a surgical oncologist. I'm a critical social scientist. I have a deep belief in the fact that our current reality is shaped by social and historical context. I'm also a policymaker. I sit at multiple policy tables at the international, national, and regional level. In terms of my personal self, I am a second generation South Asian diaspora. And I think, we regularly grapple with the intergenerational trauma of colonial violence during the Indo-Pak partition. But apart from that, as you can see, I'm a woman. I'm a person of color. I too am raising two teenage children, and I feel very honored and privileged to be raising them on this land in Mississauga. They weren't too excited about the snow, though, because my husband got them to shovel this morning. But we'll keep going forward from here. So next slide, please. Why are we here? When the members of EMPaCT got together, these were the grounding charters that brought us together. They really wanted to hone in on the idea of relationships and relationships that are rooted in trust. If there were no trusting relationships, there was no fabric that could move forward. We wanted to create a space where we could listen and learn from each other with respect, and in doing so, share power with communities that have been left off from decision making, and change the conversation and build a health equity movement, which is really what the conversation is about today. If we could do the next slide, please. So why are we here? As you can see, our fabulous speakers represent the policy space, the practice space, and the research space. And we want to share some of those lessons learned with you, and then maybe think together as we get towards the end of the session. So if we could run a poll, we just want to get a pulse check on where everyone is at with a couple of things. And so you'd need to scroll all the way to the bottom to be able to answer all of the questions. But we're asking you to rate how familiar you are with certain processes, how well you understand the ways in which community-engaged health equity assessments can, should, or possibly could work, which I have to say we're still on a learning journey ourselves. And then finally, how confident are you in building in accountability and transparency? And to that too, I would say it's a constant learning journey, but let's learn from each other. So thank you for taking part in this poll. We'll just wait for some results to come in. And if we could move to the next slide, please. So today is about change. I think we're going to use this word so often in the next hour. If we could go to the next slide. It fundamentally starts by, I think, just recognizing and reflecting that our systems are perhaps not working so well for different groups of people. But then exploring that further and wanting to get an understanding of, why is it that services are appropriate, acceptable, approachable, affordable, available for some people, but not for others. If we can go to the next slide, please. One of the ways to grapple with those questions is by using a tool or decision support framework. It's a structured process. It's known as a health equity assessment. It's also known in different regions as a health equity audit, health impact assessment, health equity impact assessment. In the world of academia, we can come up with 10 names for basically the same thing. Fundamentally, what they're used to do is, let's think about inequities that could be happening. Let's make a decision about which inequities we can address and use that to inform policies and then evaluate effectiveness to see if they worked or not. The next slide, please. Traditionally, these health equity assessment tools have been used by professionals. And I think that's been a great starting point because it's given us an entryway to take a pause and reflect on what's currently happening so that we can move in a better direction. So traditionally, HEAs are done by policymakers, program planners, health professionals, and researchers. If we could go to the next slide, please. But today, our conversation is really about how do we build in people who are at the core and center their perspectives, their needs, their priorities, their living and lived experiences, and say, well, let's do a health equity assessment together so that collaboratively we can come up with a better outcome. But you can't just throw a group of people together and hope for a good outcome. It needs planning, it needs deliberate effort, and it needs a lot of processes that act in safeguard of A, the process, because you want to achieve outcomes for change, but B, so that people who are involved are actually involved in a meaningful way. Next slide, please. I recognize this slide says lived experiences, and it should be saying living experiences. Experiences are not always in the past. Some of them are ongoing, they are recurring, and if not appropriately considered in a trauma-informed way, just the very act of putting people together can be traumatizing. Next slide, please. And in healthcare, very often this is a space where we've come from, where we've designed systems and we've sort of told people about them, or we've informed them of what options of care are available. So these are the options that you have. This is what you can take. And it's what Paulo Freire describes as the instructor-instructee relationship, where one person is in a higher position of authority and understands or supposedly understands what the other person needs. If we go to the next slide, another way to do this is the idea of dialogue. So we bring people together, create a safe space where each person respects each other. There's an opportunity for co-learning, and together we can identify the problem together. So we do problem posing together before coming up with solutions, instead of just informing people of what the solutions could be. Next slide, please. And over to you, Elise.
Yeah, so we partner with people and projects where there's a clear pathway to change. This does not waste the EMPaCT community's time, and it's not tokenistic. Today, we have 3 EMPaCT partners who came to us with very different projects and needs. Shari with a practice project, Karine with a policy exploration, and Carolyn with a research project. Next slide, please. As a non-traditional model of patient engagement, we flip the paradigm so decision makers request a seat at the EMPaCT community table, and we choose who we work with. Most models of patient engagement require us as patient partners to come to the healthcare table or to the research team table. The community table flips this paradigm. In this model, the community table exists independent of any projects. It does not serve any one entity. In our case, we're hosted by Women's College, but we also serve projects across multiple health and social organizations and across various jurisdictions, local, regional, and national. Next slide, please. So what do we mean by diversity? Diversity, a diverse community, includes a wide range of expressions and experiences, including gender, ethno-racial, sexual abilities, and other identity factors. And what do we mean by community? Communities are by their nature relationship-based. When we started with EMPaCT, we started by talking with people we already knew, and we co-designed EMPaCT organically, grounded in those relationships and discussions. We're a community and therefore do not have terms of reference because terms of reference are transactional and not relationship-based. Communities usually have a common factor or purpose, and we came together around the common purpose of health equity. Next slide, please. So we're going to start with the discussion. Why did you approach EMPaCT? And so I'm going to ask to start with, Karine, if you could speak to this question, and then we'll ask the others to join in.
Thanks, Elise. I'd be happy to. So just to give you some background, as I had mentioned, I was working with what was called the Canadian Drug Agency Transition Office, and we were working to help launch the Canada's Drug Agency. And the work I was doing inside of that was to help develop what would be an appropriate use of medication program that would move over into the Canada's Drug Agency. And appropriate use in this context means the idea of people getting the right medication at the right time in order to provide the greatest possible benefit to their health. And part of the work we were doing there was to develop an appropriate use of medication strategy that would involve all parts of the system, from communities and patients to clinicians to researchers to programs to provinces and territories. So the appropriate use, as I mentioned, was going to be a core program of the new agency. And to ensure that it met the needs of both people and communities now and into the future, this was seen as a guiding principle. We wanted to ensure that we got it right. So we were most concerned about potentially building in processes or structures that might have unintended effects once the program was launched within the CDA. So to help inform us and thereby the CDA, we looked at developing an appropriate use engagement model that would meet the needs, and that's why we reached out to EMPaCT. Most specifically, we wanted to learn about their engagement experiences. We wanted to hear from the community about things they liked, they didn't like, barriers they might have faced, how they would ideally like to be engaged in program development, and learning a bit more about the importance of that feedback loop so that our engagement activities and the information that come from them are then fed back so people can understand how their input impacted the evolution of the programs and policies. So that was kind of the background of what brought us to the EMPaCT table in the first place. And with that, I will hand over to Carolyn.
Thanks so much, Carrie. So for us, we came to EMPaCT as a group. I was leading alongside my colleagues, Dr. Mercer Burge and Dr. Jay Shaw, a Catalyst grant that had been funded by the Canadian Institute for Health Research. And this grant was intended to help us better align our technology implementation to values of models of person-centered and integrated care. Because we had a sense in looking at the environment that technology was being put in place without always considering what was kind of core and meaningful to some of these models of care, which was often around what was core and meaningful to the people they were trying to serve. So we had brought together a consortium of providers and including clinicians and policymakers like Karine and industry leaders, as well as quite a few patient, caregiver, and community partners. Though when we looked across that group, as we started developing our dialogue work and trying to develop out our values statements and our implementation strategies, we noticed we had a lot of the same types of patient and community representatives, very similar to Elisa's experience that she shared earlier. And we really wanted to be able to represent a diverse array of values that are important to Canadian people. So we came to EMPaCT as a means to kind of check what we were hearing from our core team and bring in a really new and different perspective on this very deep question around what are the values of our models of care and how do we align technology to that, which has moved forward, and now we're building out new tools based on that foundation. So it's been a very enriching experience working with them. And with that, I'm going to hand over to Sherry to tell her experience.
Thanks, Carolyn. So, as I mentioned before, Novartis creates medicines to treat diseases, and we recognize that access is a really important part. And we also recognize that depending on where you are, your background, access can be very different. Access to care, delivery of care can be very different, and also outcomes can be very different for different populations. So when we were reflecting on kind of our role in this and how we can maybe have an impact, we decided to reach out to experts to find out, maybe what role we can play and how we can maybe give back in a way that was meaningful and thoughtful and inclusive. So my former manager and I had heard of EMPaCT from a webinar similar to like the one we were on today. And we reached out and we had a conversation with Elise and Breen about co-designing a capability building program for us to help create and launch a community investment program. Sorry. Oh, am I back? Okay, perfect. But yeah, like I was saying, just to recognize that we weren't the expert in this space, but we wanted to speak to communities that we don't usually hear from, to know what's the right way to launch this program, and how to make sure that we're evaluating the projects that we do receive with an equity lens.
So thanks you all for that. Next slide, please. So the EMPaCT community felt that we could offer some insights into moving towards health equity through our own version of the HIA, a community engaged HIA. Next slide, please. So let me introduce you to the EMPaCT 5 steps to a HIA. We refer to this as the bookend diagram, kind of because it's the way it's drawn. At one end is the setting up of a safe space for engagement. At the other is the closing of the loop, which incorporates accountability and learning, both elements actually of a learning health system, in fact. In the center are the focused 3 steps that occur during the engagement and afterwards. Next slide, please. So this is a deeper dive into the process. As EMPaCT, we have co-created a formal process for engaging with those who come to us. A key part of creating a safe space starts with holding 2 meetings with the EMPaCT partners, the decision maker and 1 or 2 key team members, coaching them to achieve the best outcomes from the engagement. This is where I, as a patient partner of privilege, help the team members to set up the discussion in the most effective way possible. The second meeting is to prepare the team how to describe their work in a way that is easily understood by the EMPaCT members. We also provide the EMPaCT community with the project materials beforehand and take time during the meeting before the consultation to connect with each other and to learn a bit about the project. So that's part of creating a safe space. Steps 2, 3, and 4, the engaging with the EMPaCT community, this is where the decision maker and 1 or 2 key team members will engage with us in a virtual meeting to identify and analyze the inequities, and to think about the changes that could happen and to make recommendations for those changes. After the EMPaCT partners leave, we spend a little time as a community discussing the project and really trying to hone in on what is useful for the people who've come to us. In the end, we close the loop with writing a report that encapsulates our recommendations and key findings, and we provide that to the EMPaCT partner. The EMPaCT partner, in turn, is asked to provide feedback to us so that we know what changes have been made, and as a result, and what the result of the engagement has been, so we can learn and understand either the changes that have happened or why they have not happened, because we can learn from things that don't happen as well. And Bree, do you want to weigh in on this one?
Sure, thanks, Elise. I think I'll just reflect on the comment which I made earlier, that you cannot just throw a group of people together and hope for a good outcome. You really need to take a lot of time to think about certain steps and processes that are needed before people can come together to engage in meaningful dialogue. So, as well as meeting with decision makers, and you see 3 of them on the call today who are here with us, and that was a key part of the process, that it has to be a person who has enough authority to take a decision. We also engage with our own community outside of that space. We grow our community, we nurture those relationships, and then we're all set up for a space that is conducive to a dialogue. And we take time to close the loop so that everybody has some kind of feedback from what happened. If we can go to the next slide, please. I would love to ask our panelists about your experience going through these steps and processes. And I realized it was quite a bit that we asked you to go through. It was quite a bit of commitment from your end, including budgeting for the engagement. So you invested your time, you invested your money, you invested your energies, you were open to feedback, and you engaged in co-creation. So can you share your experience? And Kiri, maybe I'll go back to you to start us off.
Thanks, Ambry. And I think that probably makes perfect sense, because I'm actually going to speak to the first part of that process, that idea of setting up a safe space and the prep work that went into doing that. And Elise and Ambry have both very already emphasized, but I will further emphasize that how important that first part of the phase was. I want to acknowledge that we were lucky. We actually had a bit of an ace up our sleeve in this process, because Ambreen was actually a member of our advisory committee. So we had a pretty solid understanding of what we might be getting into and what exactly the benefits that an EMPaCT community engagement HIA could bring to our work in helping develop this appropriate use strategy that I alluded to earlier. But while we were confident that we were coming to the right place, we also knew we had a pretty messy policy topic. We were talking about medication access, the use of it, getting the benefits out of it, all of these things that can be very technical, but also can be very personal in terms of somebody's health. And that messiness could make the discussion pretty difficult, but also could make it a bit of a space where people felt uncomfortable. So the team in those 2 meetings that Ambreen and Elise alluded to, they were absolutely incredible in helping us get prepared for this session. They worked diligently to help us explain our project and what it is that we were trying to get out, and making sure that we scoped our questions in such a way that they made sense. We speak often in the policy world in very bureaucratic ways, and that does not speak to most people in community. So it really helped us to kind of bring our language to a level that could help people understand. So in short, they magically transformed what we provided, which was a bureaucratic Government of Canada deck, into something that actually sparked a meaningful conversation, instead of what would probably have been the crickets that we would have gotten if we'd gone with our original deck. So we were so helpful that every step of this process, from the scoping and prep meetings through the engagement and then the follow-up, was always incredibly insightful. The team that we met with always had such insightful comments and thoughts that made us look at the work that we were doing in different ways and not necessarily question whether we were doing it right, but see it from a different perspective, which is so important when we're developing policy, as I mentioned, and kind of bringing people to the work that we're doing, instead of simply designing work for an outside audience without really thinking about where they fit. And so with that, I will conclude, and I will pass it over to Sherry.
Thanks so much. So, similarly, I think the safe space was also really key for us. Within our first engagement with the team, we realized that we had to kind of change the way we even introduce ourselves. So similarly, we have a very kind of corporate way of introducing ourselves through our positions, our job titles. Um, but we were quickly and politely told that maybe a different way of doing it would be to talk more about what drives you, what interests you, what's important to you. And by doing this in a safe space, we were able to make connections. We were able to stop and reflect and, come together in terms of what drives us, what the commonalities that we have towards this work and the purpose. So that was a huge part for us, because usually within our day-to-day we're going, it's very fast paced, but it causes you to take a pause and reflect, which is what this work requires. And I'd also say the change of pace again in terms of trying to understand those inequities, the current issues that there are, and also giving us a chance to reflect on our own biases and privilege, to start with ourselves before kind of reaching out to see what we can change. So that was a huge part, and I think really beneficial for the team to have that time and space to do that. It was an adjustment for sure, because in the beginning, you are a bit shocked, I guess, by the pace. And we had some of those conversations in terms of we kind of just changed how we were introducing ourselves. Did we accomplish anything? But absolutely, because you're able then to learn so much more about each other. And like I said, find these commonalities to move the work forward. So that was a huge part for us. And Carolyn, I'll pass it over to you.
Thanks so much. So I think I'm rounding out the conversation a little bit with a reflection about the closing the loop component. That was a really important thing for us, not just in engaging with impact, but how we think about our ongoing engagement activities through other projects, not just the Catalyst grant, but the other trials that we've run and the other studies, because we've got lots on the go, as you might anticipate. So I think in going through the closing the loop process with EMPaCT, we were able to kind of see how they were sharing the learning back with us through reports. And the report we were able to embed right into our own study reports. We were able to share that with an international audience at a conference as part of the findings of our deliberative dialogue. And we were able to feed that back to our consortium members as part of the reflection on what we were learning through the other parts of our processes. So we were able to feed back, and then we were tasked from EMPaCT to feed back to them how the engagement meaningfully improved the project. So that allowed us to kind of take a critical lens on all of the ways in which that engagement had changed our thinking and it had advanced the work we were doing. So in being able to feed back to EMPaCT, that changed how we were thinking about feeding back to our patient caregiver and community partners who are in the consortium. And it's changed the way we think about our feedback loops on our other projects. So we have, for example, an advisory committee that we're happy is very representative of the communities we're serving for a transitions project we have going in Toronto and Mississauga. And now we're very intentional about how we feed back to that committee about how what they have shared with us is influencing the project in really meaningful ways. So it not only was a learning for this particular experience with EMPaCT, but it has informed myself and my colleagues and other researchers on this project how we do engagement well by thinking about how we share back what people have told us and how we're changing our thinking because of the time and energy they share with us as partners in this work. So I thought that last process was really important, building on Karine and Sherry's experiences in the earlier phases, which were critical, but the closing the loop thing has changed a lot of the way we work.
Thanks so much, Carolyn. I'm going to keep you on board while we change to the next slide and the next question. So could you give us in a quick sum up of how you learned from the engagement and what you changed actually in your project, and what were some of the ripple effects?
So I think I'll build a little bit on what I was just sharing around closing the loop. But I think one of the things about closing the loop, about not just learning and asking somebody a question and learning their answer and then feeding it back, but in the feedback, it's not just to the people who telling them how did we engage, how did we use the information that you shared with us and change our processes. But in feeding that back to our research partners that were Canadian as well as international, and sharing it back to international audience, and sharing it back to leaders, policymakers, industry leaders, and clinicians, it kind of engendered a sense of humility across everybody. Because part of what we were doing in that project was bringing together experts in a deliberative dialogue. So we come with that sense of expertise in what we know based on our own experience. Having that reflected on from a group with very different lived experiences and very different perspectives allowed everyone to have kind of sit back and have a critical thought about what their expertise really meant, and that it came from a particular place and time and experience that could be seen very differently from a different set of eyes. And it opens up our eyes, lots of aha moments around what the challenge even was that we were trying to unsolve, how we even think about what a value is, what implementation means, what technology even is to allowed us to kind of critically question what we thought we knew going in. And that is a practice that I see not just in our internal team, but anybody who's worked with us and anyone in that consortium, that they seem to be continuing over time. This practice of humility and questioning what we think we know, and understanding better that what we know comes from a particular place and might be different in a different environment. That is very meaningful from a research perspective, right? Because it opens your eyes to very different ways of understanding challenges and solutions and how we can move forward. And I think I'm really curious to hear about Karine and what you experienced and what you've learned from the policy perspective.
Thanks, Carolyn. So we learned quite a bit. Our engagement certainly helped reinforce, as you mentioned, it kind of reinforced some of our initial understanding. So yeah, awesome, great, we're on the right path. But it also brought to our attention some issues and potential unintended consequences that we might otherwise have missed as we set up this new program. And this included the importance of creating that safe space for engaging on topics that can be traumatizing. And as I mentioned, we had a really complex policy topic. We came into talking about medication, and knowing that some people have had issues in the past, that this could be traumatizing to their ability to participate. So creating that safe space, just learning how important it was that we had done that, and that needed to be done whenever we were going to be discussing anything that came out of the appropriate use space, was incredibly powerful for us to learn. We found that by creating that safe space, people were more comfortable sharing their stories. And so we were able to learn from that. And we wanted to ensure that that became part and bedrock of the new program as it was being launched inside the Canada's Drug Agency. So these concepts were that we learned through this engagement with the EMPaCT community, they made their way into the Appropriate Use Advisory Committee's final report. And that report has since been shared with Canada's Drug Agency, and it is the basis for the building of their new program. We also were able, during the transition of the work that we've been doing at Health Canada over to Canada's Drug Agency, we actually had a specific session where we sat down with the executive and talked them through at length what we had done with EMPaCT and what we had learned from that engagement, and what we felt they should ensure that they kind of carried forward in their work going forward. So ripple effect wise, I'm really happy to report, and I actually learned this backdoor yesterday from Anne Breen, but the Canada's Drug Agency is coming back now to EMPaCT on this program to talk to them further. So fantastic. They really heard what we said, and they understand the value of this process. Not only that, they've actually developed their own Appropriate Use Advisory Committee that's going to take this work forward inside the new agency. And they've actually moved over several members from our committee to their committee. So there's continuity. Members that went through this impact process with us, that learned from us, saw the benefit, incorporated into the report, are now the ones that are going to be over at the new agency implementing that report and implementing the strategy. So we're super excited to see where this goes into the future. And with that, I will pass it back over to Sherry.
Thanks so much. There's so much that we've learned and continue to learn as we just actually announced the winners of the first Health Equity Initiative. I would say from that first session that we had regarding biases and privilege, that really stuck with us. And then even beyond this program, we brought some of that learning back to the organizations through lunch and learns here internally. We've had presentations and conversations with different leaders in different regions across the organization. So we've had a lot of interest in terms of how we co-designed the capability building program, and then how we implemented this initiative, even from the language that we used. And how we outreach to communities. Going into it, we were hoping for about 40 applications, and we ended up getting over 130. So I think it really goes to speak in terms of the learnings that we did get from impact, how we implemented that, and really saw the uptake in terms of outreach, and also using the tools that we had from impact regarding the evaluation process. We were able to support really 3 amazing projects and initiatives that are done by communities for their communities. So many learnings along the way. Unfortunately, I know we don't have all the time to go through, but I think that again, that sharing back, that feedback loop is really important. That still goes on, because we hear feedback from different people that we've engaged with, or even groups that participated in the initiative, and we're always happy to share back with impact the impact of their work.
Thanks so much, Shari. So in the interest of time, we're going to skip ahead a couple of slides, and maybe if we can go to slide 32, please. Elise, I'll pass it over to you to close us out so that we can save 3 or 4 minutes at the end.
Okay. So first of all, the tool, the health equity tool, is on our website. I just want to put that out there. So to close, really, health equity work isn't easy. It can challenge the status quo, and not everybody is ready to do it. Not every person, team, or organization is ready to embrace the upheavals and uncertainty that change brings. So I want to say bravo to our 3 panelists, all of whom in their unique way have had the commitment and the courage to challenge accepted ways of doing things, found their champions and supporters, and made change. Thanks so much for sharing your experience with us. And I now go to the next slide, please. Like to ask for one key thought around what system level strategies you feel will promote the use of a community-based HIA more broadly. And I will start with Shari.
I will just add to that folks, we literally have 30 seconds to give you the spotlight for this. So give us that one thought in 30 seconds. Thank you.
Yeah, I will make it quick. Those internal champions, like you said, Elise, because it is difficult to change kind of the ways of working that are traditionally done. You have different people coming to the table with different experiences and different understandings. So sometimes you do have setbacks, but having again that core team there around that common purpose, holding each other together and working towards that common goal, you're able to move things forward. So even though there are those challenges, being able to push forward by having those champions alongside does help.
Great. Thank you.
From a research perspective, given the time, I think really important as our institutes start to champion this and create kind of more firm resources that we can leverage, particularly for early career researchers. so that we're not working just on soft money to be able to do engagement work that it's kind of core to what an institute does, like grants administration or anything else. With my few seconds, I also do want to acknowledge Ms. Jennifer Major, who is another co-lead of the project. I forgot to mention her name, and Healthcare Excellence Canada, who was a partner on that through Jennifer's work. And with that, I'll hand to Karine.
Thanks. And from a policy perspective, really, we need to change the paradigm of how we develop policy and think a little bit more about making an HEA a standard of how we develop and implement policy and not a novel approach of how we might want to do things. So embedding it into the policy development process, much like we've done now with SGBA, with official languages and all sorts of other things, that it becomes something that we need to do prior to a policy or a new policy or program being approved and implemented. And with that, I'll hand it back.
Thanks so much. If we could go to the next slide, please. EMPaCT is a disruptive innovation. Sometimes to create change, we just need to go from scratch and build up. So bravo. And again, thank you so much to everyone who's been part of this call. If we could go to the next slide and the one after that, we'll ask you to take part in a poll. And with that, I'll pass it over to Andrew to lead us into the close. Thank you.
Thanks, Andrew. Thanks you all. Fantastic to hear great variety of case examples. Those always really make things come alive for me. Could we go to the next slide? We're not going to have time for questions based on the presentation, but so the next slide has a QR code and web address to learn more about EMPaCT. And we'll put the email address for EMPaCT for the team in the chat. There was great discussion around the ideas about introductions and some good comments about generational shift, understanding of engagement practice and engagement practice in the complexity of the healthcare space. I think there was a question about how we can use our collective voice to make change that's more sustainable. Perhaps that's a conversation for the NEN to continue to have in coming discussions. We also have another poll. We wanted to ask if you have made a new connection. So much of the work of the NEN is about building connections. So before we wrap up, we want to know, have you made a new connection with NEN or with EMPaCT through your awareness of their work that you will draw on in the future? And while folks are filling that out, I want to just again thank our speakers and the team from EMPaCT for their excellent presentations over the course of the fall. Certainly lots of amazing food for thought and detail to build into our practice. I want to thank everyone who's joined us today and throughout the series. Hope you'll stay connected with EMPaCT and with the NEN. And we encourage you to check out the recordings of these sessions. The first two are already up. This one will be added once it's prepared. As we close in the last a minute and a half, I have a couple of reminders. For those of you who are on this call and are NEN members, a reminder that we will be transitioning in 2025 to meetings every other month for 90 minutes to allow for more time for generative discussion and networking. Meetings will still be on the first Thursday of the month, but we will not be meeting in January. So the first meeting of 2025 will be the first Thursday in February. And members of the NEN will get a calendar invite email with those dates for 2025 shortly. We'll also be sending an email shortly asking NEN members for suggested topics, presenters, volunteers for chair and note taker for 2025 meetings. So watch for that form and please fire away in terms of suggestions. Lots of suggestions will help us make sure we have great, rich meetings next year. And finally, a reminder that NEN is transitioning to this leadership team. Belinda, Moira, Heather, myself, we will be continuing to work with HEC's secretarial support to host these sessions, and you can continue to use the NEN email, which will be shared in the chat as well. And anyone who's interested, who has participated in this session or one of the EMPaCT sessions this fall and would be interested in that continuing conversation on engagement and equity in healthcare and other topics, please let us know you're interested in joining them by emailing that email address as well. So right on time. Thank you again, all. This concludes the Engaging with Everyone webinar series. Thank you so much. Take care and happy holidays to all of you.